Welcome to the Health AI Brief, breaking down the AI shaping our world one concept at a time. Today we'll do the first of our second type of episode, where we take a deep dive on one new research paper, product or news story or anything that's interesting in the space. We'll call these deep dive episodes, and they'll be distinguished in the feed with a DD prefix like this one has. Today we're going to do a deep dive on a single paper that's generated some buzz, and for good reason. It's titled AI-based clinical decision support for primary care, a real-world study, from a collaboration between OpenAI and Penda Health in Kenya. It's been hailed as a potential breakthrough, but we'll see it also serves as a critical lesson in the standard of evidence we must demand in healthcare. So for years, a big problem in health AI has been bridging the model implementation gap, getting clever algorithms to actually work in a busy clinic without driving clinicians mad. This study tackles that head on. So researchers deployed an AI tool called AI Consult that runs silently in the background of the electronic patient record, acting as a kind of clinical safety net. And the big idea is to only speak up when it spots a potential error, using a simple traffic light system to avoid alert fatigue for the clinicians. So on the surface, it sounds like a solution we've all been waiting for. And let's give credit where it's due. The design of this tool is one of the most sensible that I've seen. It shows a clear, deep understanding of the cognitive load that's often on frontline clinicians. And it's not another button to click, it's asynchronous, and it only interrupts for serious issues. One interesting element was a kind of training effect that they found. So over time, clinicians using the AI started to make fewer mistakes on their own, even before the AI had flagged anything. They interpreted this that it's acting as more than just a passive safety net, and that it's a kind of active on-the-job education tool. But I guess another interpretation is that just having this system watching over everything you're doing might cause people to be a bit more kind of thorough and detailed in what they do. So in general, the design and concept of the study I think were excellent, but the devil, as always, is in the detail. And so on the surface, the numbers in the abstract look great, reporting a 16% reduction in diagnostic errors, 13% reduction in treatment errors. But how these numbers are reported and what they're based upon raises some red flags for me. So first, the abstract leads with these big, impressive sounding relative risk reductions, like a 16% reduction. Sounds fantastic. But reporting relative risk can be slightly misleading, rather than absolute risk, which gives a clearer indication of the magnitude of an effect size. And more importantly, these headline numbers are presented as just clean percentages without clear confidence intervals. They don't give an indication of the range of uncertainty around the result. And actually, in reality, the p-values and the significance of these differences are quite marginal. And leaving out these details kind of makes the findings seem a bit more certain than they actually are. And this style of reporting feels a bit less like a dispassionate scientific summary and more like a kind of marketing push for a product. But kind of really digging down into the details, that kind of one of the biggest claims is that of reducing treatment errors. But that's built on quite a surprising baseline that in the control group without using AI, a staggering 60% of visits were judged to involve prescribing an inappropriate medication. That's 60%. And I kind of find this number a bit too high. It kind of makes me question the entire evaluation. It raises the possibility that the AI's impressive looking benefit is partly because the starting point of the errors was unusually high. I mean, I can understand this high level for patients not being provided education materials. I think that is a reality in true clinical practice. But actually determining that a majority of consultations had an inappropriate medication prescribed, I just find slightly difficult to reconcile with this being applicable to other healthcare scenarios. And then finally, for any tool being considered for a frontline use in clinical care, there's always the kind of money and business case question. So the paper's commendably honest about the cost, and so using the AI tool increased the average consultation time by about 3.5 minutes. And now if you envisage that for a GP seeing 25 patients a day, that's nearly an hour and a half extra time, the equivalent of seeing 3 or 4 patients that you can no longer fit into your day. And so in a system straining with access problems, there's massive operational costs to potentially implementing this. So what does the service get in return for this potential hit to productivity? Again, the paper is clear that there's no statistically significant difference in patient-reported outcomes. Patients didn't feel any better 8 days later. Now, to be fair, the real health benefits might take longer to manifest, but as it stands, the evidence is asking a manager to implement a tool that reduces patient throughput for no immediate measurable gain in how many patients actually feel. So it's currently it's a bit of a non-starter. So I think for the time being, the idea is stronger than the current evidence. So I'd rate this as a promising but needs major work still. So just to reiterate, it's an impressive effort and the use case is exactly what's needed, but the evidence as presented doesn't justify the practical costs. This is my issue with so much of the field right now. A company pitches a tool that seems great based on the top-line data that they've chosen to highlight, but the actual nuts and bolts are hidden. The combination of longer consultation times, a questionable baseline, a lack of patient outcome benefit, and a reporting style that feels a bit more like a marketing pitch than a scientific, dispassionate evaluation means I'm not seeing convincing evidence currently. Maybe faster, better models will one day solve these problems, but for now the paper's a crucial reminder that in healthcare we must hold ourselves to the highest standard of evidence. It's a great concept, but there's still a long way to go. So that's all for this week. If you found this helpful, don't forget to like and subscribe so you don't miss future episodes.